I don't always remember. I'm going to turn the webcam off for a minute, and then I'm going to crack on. So, a lot of you will have had some experience about undertaking respiratory assessments, but what we're doing today is having a look at some of the things that you've been doing and consolidate some of that. So the aim of today is to focus on respiratory assessment, but is also to look at two of the common respiratory problems, asthma and COPD. As I said, we'll pause for question and talk along the way, and let's have a look at what respiratory assessment's all about. So why do we do it? We're looking at respiratory status of the patient, but the respirations and the way in which somebody's breathing does actually provide us information relating to other body systems, such as cardiovascular and neurological. So there's quite an important piece of the jigsaw puzzle, as it were. It's also well known that breathing is the first vital sign to alter in a deteriorating patient. So when you're thinking about A to E, think about it, airway, breathing. It's important that you do look at people's breathing and make a really good assessment. Breathing difficulties is known to precede adverse effects with an increase in mortality. In other words, it's a predisposing factor that people are deteriorating and potentially going on to die of cardiac arrest, etc. So let's have a look at this in more close. So I can't emphasise over enough, it's really important that you know how to undertake a basic respiratory assessment, and also to be able to interpret what it is you're seeing and what it is you're finding. And that knowledge you will build on as you go through this year and as you go through subsequent years to understand more in depth about what it is you're finding and what it is you're recognising. So we have some terminology for you. What a big long list there is there. These things you may have heard bandied around, you may see them written in patients' records, but they're common terms used. I don't know whether if you realised that you needed to know about Greek and Latin before you started your course. And these are where these words come from. And anatomy is one of the oldest medical sciences performed, and hence the Greeks sort of have a lead on it. It doesn't help if you're stumbling and trying to stumble over your words. So we're talking about ventilation, which is the ability of the body to actually get air into the lungs. Diffusion is where the air goes into the alveoli and diffused into all of the flare sacs. Perfusion is where oxygen and carbon dioxide exchange. Respiratory drive is the centre of the brain, and that drives how much you breathe, how fast you breathe, and the pattern of your breath depending on the oxygen levels and the carbon dioxide levels circulating the blood. And respiratory rate, you should know that one by now, the speed and the rate of breathing. A few others, bradypnea, cyanosis you might have heard talked about. We'll have a look a little bit more in detail on that as we go along. Dyspnea you would likely to have heard, difficulty in laboured breathing, hyperventilating and hypoventilating, the opposite ends. Things that you may have heard or may not have heard, or if it's heard it might have gone over your head, is things like hypoxia, low levels of oxygen in cells, hypoxemia, low oxygen levels in the blood. Orthopnea you will hear. It's dyspnea, unless this isn't that right, and we'll pull those in as we talk about patient assessment. Tachypnea, high respiratory rate. It's like all the other things that we've got to learn the terminology. Here's a few for you there. So when do we do respiratory assessment? We do this as part of the initial patient assessment. We do all of their vital signs to use as a baseline for observing further. We also look at respiratory assessment to monitor the patient ongoing process, and looking at changes to the baseline and observations following surgery or procedure, for example, where you would be giving an anaesthetic which would naturally affect the respiratory rate. You may be using it for investigation, and certainly if somebody has had chest trauma, for example, you're definitely going to be looking at it. And in emergency situations, or situations where people are deteriorating. I've already talked about A to E assessment. And then patients receiving intravenous fluids, and also people receiving a blood transfusion or blood products can early detect allergic reactions to transfusions, change in the pattern of their breathing. So all these things. The other thing is we're looking at maybe evaluating patients' response to things that have been done or medications such as being given opioid analgesics, morphine and such like, actually depresses the respiratory centre, so the patient's breathing does become less and actually can stop if you're not careful. Patients receiving oxygen therapy, it's important to monitor how effective it is, is it affecting, improving their respiratory rate. Then the other thing is bronchodilators. We'll talk a little bit more about that when we talk about asthma and COPD, but drugs given to open the air passages to increase the capacity for gaseous exchange. And then progress or deterioration of respiratory state of patients with long-term respiratory conditions, and so you can look at how they are now, how they were before, and look at how therapy may be affecting. So those sort of kind of typical things. So what do we do? You've already done this when we started in the skills, and do this in skills is looking at undertaking vital signs assessment. One of the things we talk about is gaining consent and explain procedures, but you already know they say, can I take I'm going to record your breathing, is that okay to do that? This is what I'm going to do, I'm going to look at your chest rising and falling. And we've already discussed with you that actually doing that can affect the way in which people do breathe, because it will, there's what's called consciousness of it all. So usually it's common to can I take some vital signs? You're going to take somebody's pulse, and while you're taking the pulse, you're actually going to be counting the respiratory rate. It's important to have the person rested and not engaged in physical activity. So if you're worried that somebody's become suddenly breathless, just double check they haven't walked back from the toilet somewhere, or that they've walked up flights of stairs, and you're basing it on resting respiratory. Sitting upright to allow for good lung expansion at a 45 to 60 degree angle is anatomically the best way to get good lung expansion. Most of us are either upright or sitting in chair day to day. At night time we lay down, we have pillows to help us comfort our neck, but also can affect the position of the chest for breathing, and it's all of those kind of things. So with a lot of things when we're doing assessments, a step beyond the basic kind of assessment that we do is to look, kicking off. You count the rate for a minute, you know that, because you won't necessarily, if you do it for any less time with somebody who has got breathing difficulties, you're not going to be able to get the rhythm or understand the rhythm and ascertain that the rate and the rhythm are even throughout. You're looking at the depth of breathing. You're looking to see how much air is being sucked into the lung. Is their breathing shallow? Is it normal, or is it deep? Because if it isn't normal, then potentially something's not right. I've talked about the regularity of it all. The other thing we're looking at is the work of breathing. So the effort is taking to breathe. I'm sitting here talking to you. I'm breathing quite lightly. The effort I require to breathe, and you sitting there listening to me, is quite minimal. However, again, people who have got breathing problems or diseases that affect their respiratory tree will potentially need more effort to suck that air in, to breathe it out, and for gaseous exchange to take place. One of the things that we notice is what's called accessory muscles of ventilation, which would indicate that their breathing is laboured. They've got dyspnea. So your accessory muscles ventilation is your shoulder girdle. So you're all sat there now listening to, I don't know, somebody could stand up on the phone, putting the kettle on. But if you now have breathe in, and as you breathe in, raise your shoulders, you will actually feel more air kind of going in. So that's your shoulder girdle for accessory muscles of ventilation. The other accessory muscles are the intercostal muscles, the muscles between your ribs. the spare ribs, you know, the ones you have at the Chinese. If you can see that the rib cage is moving again, very visibly again, and you're using your shoulder girdle, accessory muscles of ventilation. Pursed lips and nasal flaring are also an indication of breathing. So pursed lips, if somebody's breathing out and their lips are this shape, so you're creating a narrow passage for the air to come out, means that by pressure you're actually holding air in the lung, in the alveoli sacs, for longer than if you didn't. So by doing this, and this is not something somebody consciously does, it's something that's part of the anatomical mechanism that takes place to increase gaseous exchange when the oxygen levels are low in the circulating system. So you will see pursed lip breathing in people who are struggling, and it's a good indicator that they really are struggling quite a bit. The other thing that happens as well is when they breathe in, you'll see the nostrils also moving, so every effort to increase. The other thing that you might see as well is about positioning. Now, if you remember a minute ago, I talked about 60-degree angle, sat upright. That might be still not easy for people to breathe. People with breathing difficulties tend to need to be sat very well upright. You and I sitting here now are breathing in enough air to fill about a quarter of your lung capacity. If your lung is deteriorated and there are problems with gaseous exchange, more effort is required to suck air in to get it into the right areas. This is why the accessory muscles come into use, and this is also why the intercostal muscles come into use. You may find that people with long-term lung conditions over years will develop a better position when they're acutely breathless, and this applies to everyone. So actually leaning forward enables the intercostal muscles at the bottom of the rib cage to actually expand a bit more, so that will increase the capacity. So you may see people with breathing difficulties who will actually not go to bed to sleep. They will sleep in chairs. They may have a table in front of them that they lean forward on their elbows, increasing the amount of lung capacity. If you haven't seen this, you will see Usain Bolt and all the other people that run 100 metres in the Olympics. When they get to the end of the race, what are they doing? They are bending forward, hands on their knees. Even some of them are actually kneeling on the floor just for just a minute or two, leaning forward, which increases the ability for the intercostal muscles to really get that air drawn down into their lungs. Now, people like Usain Bolt, which probably 30 seconds later he's running around doing a few laps of I've won the race kind of thing, and the other athletes, and you may find this yourself if you're runners as well, you will recover very quickly from that. But if you're somebody with a long-term lung condition or breathing difficulties due to some kind of lung problem, then you are going to be likely to be better positioned in this way. And you may find putting a couple of pillows on the table, leaning elbows on the table, allowing that so if you want to lean forward and raise your shoulders, you will find that actually that also helps, and you will feel that down your back your intercostal muscles waking up, hello, good morning, and doing something. What I'm trying to do for you is create a visual picture. When you go and look at this presentation yourself, you'll see there's a link to YouTube. The problem with showing YouTube links on webinars is that everything is out of sync and the sound is really bad, so that will be for you to discover yourself. So I am describing dyspnea to you. It requires substantial effort and uses up energy, which also can result in adequate gas exchange. It can be the result of airflow obstruction or infection. So something is blocking off the air passages, or something is causing airflow obstruction because of disease. And when we look at COPD and asthma, we look at how that actually affects. So picture in your mind now of what people are breathing, and we'll have a look at the characteristics. So I've already kind of indicated some of the irregularities that these characteristics of breathing can show. Slow, fast, shallow breathing can be to do with poor ventilation and gaseous exchange. Some of you may have heard or seen written terminology, chain stoking, irregular breathing and periods of no breathing, and it's a type of breathing that often occurs just before death. And this is often a sign where nurses and medical staff can see this happening to a patient and can indicate to the family that things aren't going to be too long. This is more in the sort of palliative terminal thing. If you see this in somebody who's young and ill, then you're going to be very worried, especially if it's people with asthma, but we'll talk about asthma again. Air hunger, deep rapid respirations, and with people who have got respiratory acidosis, which is a result of retaining carbon dioxide. And you may well see this with people with diabetic ketoacidosis. So when it's a bit abstract for me to describe it to you, what I'm hoping is that when you actually see this, think, oh yeah, I kind of think vaguely about Adele mentioning something like this, and then you can actually link the pathophysiology with what you're seeing. So we're still looking. So patient skin, observe the signs of cyanosis, and it should be noted, central, peripheral. Okay, there's a couple of pictures there for you. Here we go, central cyanosis, seen in the oral mucosa, but also in the lips, and also with the nail beds as well. Deep, deep purpley dusky colour. Here. This is an indicator that gaseous exchange isn't doing very well, thank you very much. Oxygen enough oxygen is getting in, and deoxygenated blood is what you're seeing. So you're seeing the dusky purple colour of deoxygenated blood. Peripheral cyanosis, where you see the fingertips change. This again can be long-term in people, but it can also again be an indicator, a big strong indicator that the patient isn't getting enough oxygen. So the other thing that can cause peripheral cyanosis is the result of peripheral vasoconstriction, so the blood vessels shutting down. If you have cardiovascular problems and the small blood vessels don't work well, then again you may see it as a sign of that. And if you remember, so you've got a crossover here with poor cardiac function, resulting in destruction of the peripheral arteries, and you've also got the cardiac. But if you think the lungs are receiving blood from the heart, and they go back to the lung, to the heart, back to the heart, to the lungs, back to pump around the rest of the body. If the respiratory apparatus isn't working properly, then the cardiac apparatus is going to follow as not having much able to do. So the other thing that you would be kind of looking for too is clubbing of the fingers. So, tissue at the base of the fingers and toenails are thickened. It's commonly associated with chronic cardiac and respiratory disease. There is a percentage of hereditary, something like 15%, but inevitably, so you may see doctors when they're examining patients have a look at the fingertips. They're looking for cyanosis, but they're also looking for finger clubbing as well, and the test would be to put fingers together as you see there. It isn't known what the mechanism is to cause this, but it is an indicative diagnostics tool. We're still looking, and we're looking at sputum. It's really important to look at sputum to see how much is being produced, what it looks like, and and it also is good to look at to see if therapy is actually affecting it. So are they getting better or are they getting worse? The word expectorating means coughing up. You're also looking at the odour as well, and you're looking at consistency, and it does help diagnosis. So we've got some green sputum here. It's called purulent. It means infection. Creamy green means that there is an infection of some kind going on in the lungs. White frothy sputum, which is here, is an indication of pulmonary edema, and this is backflow from the cardiovascular system and back pressure where the heart isn't working. So it's common in heart failure, and you get backflow, and because the alveoli sac are only one cell thick, fluid is seeping out of the circulatory system across into the lungs, and people will often describe they feel like drowning, and you can see them and it's effortlessly bubbling up. They are seriously ill and they need sorting out and treatment, very seriously ill. Blood in sputum, frank blood, here we go, red, called hemoptysis. So carcinoma or pulmonary embolism, which is a blockage in the blood vessel which ruptures, and again is that alveoli wall is only one cell thick, you often get it trickling in. The other thing, trauma, so if somebody's received chest trauma, again, it can be, if they're coughing up blood, it means that one of the blood vessels has been perforated. So I'll come back to the tumour, the carcinoma. It is where the tumour will have eroded through one of the blood vessels, one of the small arteries, or potentially one of the big arteries, and you have bleeding into the lung tissue. Usually this is of huge concern, and you may not hear to talk about lung cancer in a big way, but it's one of the signs that people are encouraged to see their GP if they're bringing up blood in their sputum, and it is because of erosion of the blood vessels by the tumour. With lung cancer, unfortunately, because, as I said to you earlier, we're all sitting here surviving very nicely on only a quarter of our lung capacity. With tumours, they're usually quite large by the time it's causing compromise of the respiratory system and causing people to be breathless and affect their ability to function and walk. And usually they're quite large by the time they're discovered because for all sorts of reasons. But there you go. Black specks in the sputum indicate cigarette smoking, but also if somebody's been in a building where there's a fire and they've had smoke inhalation, you will also potentially see black specks. Right, nobody's asked me any questions yet. Are you all with me so far? Or have you gone to sleep? Or have those of you that smoke are starting to panic? I don't know. Does anybody want to ask anything? Please type them in, and I'll answer them as we go. So I'll move on a little bit and have a look in a minute. So the next bit, we've looked, and now we're going to listen. Again, here's a recording you can listen to on YouTube of somebody with laboured breathing. But breathing patterns and the sounds they make can be highly indicative of things that may be myths. So I'm going to just wanted to triple check what I've got there. So you're listening. When you're observing a patient's respiration, you're also listening. You're listening to hear if you can hear any of the breathing sounds. If you can hear noises of breathing from a patient when you're stood by the bedside, then you should be concerned, because you shouldn't normally. People with asthma have wheezy sounds. People with pulmonary edema, you can hear bubbling and wheezing. People with chronic obstructive pulmonary disease, sometimes you can hear wheezing, but quite often people with chest infections, you can hear the sputum rattling around in the alveoli. These things can also, you can hear when you listen with a stethoscope. And I suggest that if you come across a patient who has got a chest infection or has got asthma, if you could ask if you could listen to their chest, and what you want to do with the stethoscope and see what you can hear, because the sounds that you can hear, particularly with asthma, the sounds that you can hear, if you can hear those sounds standing at their bedside, it's an alert to be concerned. So it's quite a good thing to do. Ask if you can listen, and you compare one side to the other. If you use a stethoscope normally and listen and breathe in, you can actually hear the air go down the major air passage, the main branches of the bronchus. But if you can hear other things as well, it's quite interesting, the sounds to hear, and there's some examples here on YouTube. Okay, So the next thing we do is feel. So in respiratory assessment, what you'll see medical staff and nurse practitioners do is putting their hands on the chest to see whether movements are symmetrical. I can say the wrong word, I apologise. That the chest is expanding, the depth and the quality of the movement. And it is sometimes difficult to observe chest expansion, and so feeling the chest is quite useful. Here's how chest should be expanded. And have a go on yourself or your colleagues. What I'm saying is, again, you could ask somebody with breathing problems if you mind, but it just gets you to understand the feel. It's important to look for symmetry. It really is important to see the lungs and to feel whether they're expanding correctly all over the stem. Past respiratory assessment. So, reduced chest expansion shows that volume, volume isn't going in and out, which limits potential for gaseous exchange. Unilateral means one side. So if somebody's got a pneumothorax, a collapsed lung, where air has through perforation, air has gone in and collapsed the lung, when you ask somebody to take a breath, you will just see one side of the chest rise. People with pneumonia, again, with large areas of lung affected, or pleural effusion where there's fluid in between the pleura compressing the lung, again, you may get a unilateral restriction. And again, that means reduced potential for gaseous exchange, and therefore you should be concerned. So, what other things can be used to assess? A lot of you will have seen pulse oximeters. Sorry, the telephone behind me is ringing. It will go off in a second. Some of you will have seen pulse oximetry. It can tell you what the pulse is, but also tells you what the saturation of the oxygen levels are circulating. Again, look at this little YouTube thing, because it will show you how to do things correctly and what it's all about. Essentially, you have infrared lighting shone through the finger, and what it does is measure how red blood cells are. So there are things that interfere with that, and one of them would be nail varnish. We looked at peripheral cyanosis. If somebody's got very purple, dusky fingers, you're not going to get an accurate reading. But it's a good, quick assessment tool. Peak flow recordings, there's a little diagram of a peak flow meter here, will assess the lung capacity. And again, do have a look at the video. You will be taught how to assess patients doing peak flows when we do clinical skills with you. And again, it's a good way of documenting. And people, you may well be doing it pre-therapy, post-therapy if you're giving inhaled therapy, or you may be doing this on a daily basis or twice daily, depending what's required. People with COPD and asthma, long-term lung conditions, will be doing this themselves at home and keeping records for themselves and for the people who are, medical people and nurses that are caring for them, just to see trends and changes. It is a good function test. Spirometry, again, YouTube video shows you how it's used. Some of you may see spirometry used. Spirometry is now becoming a big diagnostic tool, and you've got portable machines that they use in GP practices, and you may see people having spirometry in clinical areas. What is important with spirometry is it's used very much as a diagnostic tool, and we'll talk a little bit more about that later when we talk about COPD and asthma. And so what is being called for at the moment is for all people that would be to be properly trained in doing spirometry, because misdiagnoses take place. But that's something that came out in Nursing Times 2 or 3 weeks ago. and I was looking at the British Thoracic Society earlier this week, and there's a big thing there about training. So blood gas analysis. So this is where a sample of blood is taken from an artery and analysed. And what you analyse is several things. You analyse the circulating oxygen, so it will tell you, so we have your pulse oximeter, but this will give you an absolute definitive how much oxygen is circulating, and also very importantly, how much carbon dioxide is circulating in the blood. Because carbon dioxide can build up and become toxic and stop you breathing and cause all sorts of problems, it is crucially important to have an accurate CO2, and the only way to do it is to do a blood gas. The other thing that's measured is the pH level, to see how acid the blood is. Carbon dioxide is dissolved in plasma as an acid, carbonic acid, and therefore this is the way to ascertain what carbon dioxide levels there are, because based on the carbon dioxide levels and pH depends on the oxygen therapy that you will give somebody and subsequent treatment. So blood gas analysis you'll only ever see it done in a hospital environment or an respiratory outpatient clinic, but it is a definitive analysis of respiratory function. The other thing you may see is exercise tolerance, which is designed to see how much somebody can do before they start to be compromised, have breathing difficulties. And again, it's used in long-term lung conditions assessment. And what you would do is you may do blood gas analysis, but what you would do is you put an oximeter on somebody's finger, get them to walk up the corridor and back, and measure how their oxygenation circulation, or we call it where they desaturate, whether the oxygen levels deteriorate. This is also done to assess people for oxygen therapy, long-term oxygen therapy in the home. So exercise tolerance. The people that do this are respiratory technicians or nurses trained, physiotherapists trained, particularly in respiratory care. I'm just going to pause myself before, not because I'm breathless, because I'm getting thirsty now. Thank you, Kirsty, for your comments, which I won't share, but I just want to acknowledge that that somebody's sent me a comment. Evaluation documentation. So the results should be documented on the observation chart. If you're assessing somebody's respirations for the first time, document the rate, the rhythm and the depth, determine if they're in normal range. So you do that in the patient's records. Any results can be compared with the baseline. Information from oximetry and patient's history can be used to determine the progress and the development or the potential deterioration in that individual's health. Okay. Any more questions, folks? Yeah. Okay, somebody's asked about someone with COPD given too much oxygen. I always get asked this question, and I will have come to it in due course. So long-term, as I've said, our bodies are constantly measuring the level of oxygen and the level of acid, carbon dioxide, in the blood through baroreceptors based in your carotid arteries. When the oxygen level drops, the respiratory centre in the brain stimulates you to breathe more quickly, as, for example, our 100-metre races. Yeah. And when it comes up to the appropriate level, then you will stop breathing quickly. So that's a subtle drop in oxygen. What happens with a long-term lung condition where you have compromise for gaseous exchange? Slowly and slowly and slowly, as the alveoli deteriorate and the blood vessels also surrounding it also deteriorate, what happens is that blood will come into the lungs, but oxygen won't necessarily be exchanged with carbon dioxide, but the blood is moved on, ready for the next kind of batch, a bit like, like a tube train. Next train loads up, what's left behind will get on. So what happens is, if there's that much damage to the tissue, blood will bring the blood in, but gaseous exchange doesn't take place. And therefore, the carbon dioxide is retained and they move on. It moves on. And over the years, slowly and surely, the carbon dioxide level will slowly, significantly rise, which means the person will always have lower oxygen level and high carbon dioxide levels, and rising and rising and rising. If you then give the CO2 retainer, that's what it's called, CO2 retainer, a high flow of oxygen, oxygen will be taken into the blood, but because it's not low, what happens is the stimulation to breathe will decrease and discontinue. So CO2 retention means that if you give somebody a lot of oxygen, they can stop breathing. Now the problem is that only 25% of people with COPD retain CO2. And therefore, you can't automatically think they've got COPD, we don't give them a large level of oxygen. What you have to do is do the blood gas analysis and give them the oxygen to meet their requirements. If their CO2 is very high, then in fact what will happen is they need to have low levels of oxygen just to gently push it up, push it up, push it up. And this is why you find prescriptions will talk about give X amount of oxygen to maintain SATs at a certain level. If it was us, sort of general people who haven't got lung trouble, you would be getting high flow oxygen, high concentration to maintain SATs above 95%. If somebody has CO2 retention, you will be giving low flow oxygen to maintain SATs at maybe 90 to 92%. This is why it's important for oxygen to be prescribed, because it is a drug, and for it to be clearly decided based on blood gas analysis how much they require. That takes a little bit of time to digest, but do re-look at this again, and whenever you go and work in areas of respiratory care, you'll start to be able to put that jigsaw into place, but that is the answer to that question. Okay. Right, I'm going to move on. So, let's talk about asthma and COPD, and we'll talk about COPD first. Chronic obstructive pulmonary disease. I've talked to you about alveolar destruction and blood vessel destruction, therefore reducing capacity for gaseous exchange, and so you get it doesn't change. It's not something you can see happening one day, you'll be breathless. This is a slow, insidious disease where the person that has it will slowly deteriorate, slowly be able to do less, slowly do less and less and less until they're so compromised that they actually recognise that they might need some help, there's some problems going on. Exacerbation of COPD, so an event which is usually caused by a chest infection. Somebody gets a chest infection, and therefore if you're producing mucus, you're blocking off alveoli with big lumps of sputum, and you're reducing even more capacity of gaseous exchange. What happens with exacerbations of COPD? They say you never recover back to the way you were beforehand. However, more modern treatment will actually, and rapid recognition that deterioration and treatment will actually help. There is that. Okay, these are 2010 figures. This is the last time that NICE guidelines were presented. I've read this week, when I had a relook at these things, is that they're reviewing the guidelines for this year. So they're under review in 2016, so we might actually have some more figures, but this is what was found in 2010. 3 million people in the UK. But not all of them have had their diagnosis confirmed. 2 million undiagnosed, that's quite worrying. They're not necessarily diagnosed until they're in their 50s, and it's largely preventable. So why is all this? Part of it is the slow insidious symptoms of deterioration. And the biggie is that it's largely preventable because the biggest cause is smoking. Okay, slowly destroying the cilia, paralysing the cilia every time you inhale, and also it will actually directly cause problems with the breakdown of the alveoli. You also get tar residing in your alveoli, which break down that wall. The blood vessel becomes redundant or also becomes deteriorated, and reduce potential for gaseous exchange. You've got millions of alveoli, and it takes quite a while until you've killed off enough alveoli for you to start displaying symptoms. This is why I talk about smoking as cough, or people with smoking slightly breathless. There's that kind of thing. These things also contribute to it. Living in poor conditions, poor nutrition. It's known that most people will smoke, which sounds a bit daft with the price of cigarettes at the moment, but there you go. Males is an interesting one because there's more rise because of the demographic of the 50 to 60-year-olds, and more women were smoking as teenagers who are now 50 to 60 plus. So it'd be interesting to see the 2016 statistics. Occupation, also, it depends on the sort of environment that you're kind of in, the housing, the damp climates, and all that kind of things. If you've had childhood respiratory diseases, then again, you may be susceptible, and also in utero exposure to smoking can potentially cause that. These things aren't singly, but they can contribute to. Living in damp conditions. Occupation is another one. There are certain lung diseases that are specified, but they cause the same kind of problems. Certainly, you will see things like silicosis in mining, where people are inhaling coal dust all the time. There's also relation to asbestos, but you can actually get tumours as well from asbestosis. There are things like the clay mining industry in Cornwall. People may have worked in clay, not mining, production of clay and mining of that because of the fine, very fine powder that they may be inhaling. These things are recognised occupational diseases that are treated differently, but essentially they cause chronic obstructive pulmonary disease because of the way in which they cause damage to the alveoli. So, what is it then? Chronic bronchitis, excess mucus production, and a cough. It's considered chronic when the production has been excessive for 3 months, a year, for over 2 years. You'll have the smoker's cough we talked about, but something like chronic bronchitis. So bronchitis is the inflammation of the bronchus tree, but chronic bronchitis will be caused by dying alveoli, which interfere with mucus production. You get loss of elastic tone within the alveoli and the bronchial tree, which means breathing in and out becomes more difficult as well, and you're losing that muscular tone, this slow degenerative type thing. The other thing, I get emphysema. I've talked already about damage to the alveoli. You can get, the other one is the congenital emphysema. Alpha antitrypsin is secreted in the lungs, and it secretes surfactant, which is this solution that's a bit like washing up liquid. It allows the alveoli to be able to move freely when you breathe in and breathe out. So when you breathe in and breathe out, the alveoli expand and contract, and if you've got lack of antitrypsin, then you may well develop emphysema and the alveoli deteriorate. So chronic bronchitis and emphysema are COPD. So gradual deterioration, patchy airway narrowing, floppy airways, uneven ventilation, impaired gaseous exchange, and once it's combined, disease is recognised as COPD. Sounds all doom and gloom, doesn't it? What do we see? The laboured breathing. I've explained why that is, with the pursed lips as well, yeah. The cyanotic appearance, the colour. The other thing you'll see is weight loss as well. This is partly due to the fact, so I don't know if any of you have had, well, you have had coughs and colds, so whenever you've had cough and cold, how easy is it for you to eat and swallow things? Not easy. If you've got long-term breathing problems and you get breathless, to eat a meal is actually quite a laboured venture, and it's quite difficult. So malnutrition in COPD is quite high. What people will do is eat small snacks, little and often, may well not eat a balance of the diet that you would expect. And weight loss is quite common. And as a resultant of that, you'll have poor skin tone, you'll also have poor energy. The other thing is, if you become breathless, is it so easy to cook meals? Have you got a lot to walk around your kitchen? Can you lift heavy saucepans? Does it make you breathless? Can you put things in and out the oven? Maybe you're living on microwave dinners and all that kind of thing. You can't get out to the shops to buy stuff. You may have to rely on other people. You may eat convenience food. It may be difficult to eat big meals, so your appetite is low. Barrel chest comes from hyperextension of the muscles. You know, when we talked about the intercostal muscles. So if you keep trying to breathe in, but you're not breathing out particularly well because you've got narrowed air passages and you've got air hunger and you're breathing more rapidly, what happens is those intercostal muscles will expand, but they will become stiff and hard, and so you have this appearance of a barrel chest. We talked about pursed lips breathing. Hypoxemia means low circulating oxygen. Hypercapnia, high circulating CO2. And it's diagnosed by spirometry, as well as clinical history and clinical signs. I've talked about exacerbations. Some of them, I've talked about the infective one, but people can get non-infective causes. A change in fluctuation of temperature. Here we are at this time of the year, we're almost out of that period where you get a change in fluctuation, but up until a week or two ago, we had warm days and cold days, cold evenings, warm days. These things can cause problems for people, breathing problems. Air pollution, again, is a potential additional risk. It is extremely frightening to have air hunger, to be breathing and still feeling that you're breathless, to do whatever you can, to sit in whatever position you can, to sit there and try and breathe and you don't feel any better. It can cause this panic, and it can cause this release of adrenaline, so you get this fright or flight kind of panic. So you will get panic attacks, especially if people feel symptoms coming on. It can make them very frightened. And what our job is, we'll talk about it more in a moment, is to teach people how to manage their symptoms and how to strategies to not get themselves into a panic. High mortality and reduced quality of life. I've described some of the quality of life issue around the food thing. The other thing is, if you get breathless, you go out less, so you become socially isolated as well. Those are all kind of factors that go in, cause a bit of a miserable life, really. What do we do? The deterioration in the lungs is irreversible. What you have to do is manage to reduce any further deterioration. So stopping smoking can lower the damage. Oxygen therapy. I mentioned earlier about people having oxygen long-term at home. Bronchodilators, drugs that can be inhaled, which will open the air passages. Inhaled steroids or steroid tablets. Steroids are anti-inflammatory. They come with a big price, so short-term use. And sometimes if and so those of you that will meet people with breathing difficulties or COPD in the hospital environment will meet them when they have severe exacerbations and they may require assisted ventilation. So, how many of you, stick your hands up if you like, how many of you have come across people with COPD, either in a hospital environment or in the home environment? Oh, quite a few of you sticking your hand up. That's good. So I'm hoping some of this will actually start to help you think about what you've been doing with these people and caring for them. So quite a lot of you have had some experience. Good, good, good. So again, 2010 statistics: 5% of deaths. One dies every 20 minutes. I'm sure that will be higher when we get the 2016 stuff because of the high incidence of smoking in teenage years from the 16-year-olds who are now 60-year-olds. 80% related to smoking. Hope you're getting that message, those of you who still smoke. This is interesting. 50% die within 3 months of being admitted with an acute exacerbation. They don't get better. 8 million each year cost, 24 million lost in working days. People with coughs and colds who can't go to work. The other thing that they're also talking about, or they've talked about for a while, which that's what they're talking about, and that's what I read this week, is that the government introduced health checks. So if you're over 50, you can go to your GP and have an MOT, as it were, and they're talking about doing spirometry automatically as part of that to pick up people who may potentially have COPD. They're also saying that people who are 40, at the age of 40, really should be having spirometry as a screening for COPD. I don't know what you think about that, whether that would be of good value. 1 in 3 patients who are admitted to hospital will be readmitted within 30 days, and 1 in 10 dies within that period. Those are quite big statistics, and COPD has always been called the Cinderella of illnesses because when they brought out NICE guidelines in 2010, they've been talking about bringing out NICE guidelines for about 10 years probably, because they know it's a big cost to the NHS. They know there's a lot of people out there. They know it's a big public health issue, and it's often swept under the carpet, or it's not being recognised or acknowledged. So we're beginning to now, and if you think what screening 40-year-olds might actually do, early intervention, smoking cessation advice, look after yourself, early recognition of deteriorating signs and symptoms, it could make a difference. And that's what we should be doing. We should be making a difference as healthcare professionals. So watch this space, watch your outfit. It'll come out probably be coming in January, February next year, we'll see. New guidelines. So I'm going to ask you the same question. Hands up, how many of you have come across, I know always when I do this, there's always people who are asthmatics, not in the classroom or in the virtual classroom, but how many of you have actually cared for people who have had acute problems with asthma? So again, quite a few of you. Great. Right, a few of you. So again, let's have a look at asthma. Characterised by attacks of wheezing and breathlessness due to narrowing of the intopulmonary airways, in other words, the airways. Narrowing varies over short periods, and it can be reversible or as a spontaneous result of treatment. And asthma is one of those things that can be something that young children get with eczema and that kind of thing, and sometimes they grow out of it and sometimes they don't. Extrinsic means affected by the environment. Usually you can get an identical trigger, and you'll find those with children and also people who've got asthma. We'll go through a series of tests to see if it's an allergy-related thing very close to allergies and eczema. People can be sensitive to different factors, but pollen and house dust mites are those kind of things. What happens is you're exposed to an allergen, inhale it, and you get an immediate mucosal inflammation. Remember, I talked about the elasticity of the air passages, so those cells, those muscular cells, go into spasm and cause airway obstruction. If you can identify the triggers, you can talk about trigger avoidance, which can be quite difficult because it will affect your daily life. So intrinsic, older people, it's a chronic condition, not necessarily allergy or family. It could be associated with a chronic episode of chronic bronchitis or stress, a chest infection or that's viral, and antibiotics don't work. So that's extrinsic. So it can occur at any age, but we talked about youngsters and boys and young boys more than girls. 10% of under 10. I talked about childhood asthma going, when people go through puberty and get out of puberty. Middle-age asthma is more common in women. One of my colleagues was diagnosed as having asthma after having, a run of chest infections and resulting in sort of wheeziness and things like that. These are last year's figures. 5.4 million are being treated, 1 billion being spent. 2015, 1,500 people died, and it was the highest level for over 10 years, but there are no explanations as to why that may be. But people talk about the problems with the environment and the pollution being a potential risk. So it's abnormal reaction in the airways, spasm I talked about, the mucous membrane becomes edematous, and then there's excessive mucus production and they block the air passages called plugging, and you get airway obstruction. How do we know and diagnose? Again, the history and the clinical symptoms, we've talked about that, all that breathing assessment we talked about. Cough, breezy, breathlessness, wheezes, chest tightness, recurrent attacks. Maybe there's a family history of allergies or eczema, allergic rhinitis, hay fever. It is quite difficult to diagnose. A lot is spent on diagnosing through looking back at the patient's life pattern. There's a lot of discussion around children under the age of 5, how difficult it is to diagnose asthma in children under 5. And quality spirometry, which I mentioned earlier, again is being talked about. It's key. So this is something for you to have a look at in time. These two antagonists are inhalers. They provide quick relief of symptoms. They are called rescue therapy, so as soon as symptoms start to come on, recognising that attacks coming on, inhale, have an inhaler, and that should rescue, as they call it, should address symptoms because it opens the air passages. But a key thing is all about prevention. And inhaled corticosteroids, so inhaled steroids, are the preventive drug, and small doses taken regularly are recommended. There's a discussion about people shouldn't be just given inhalers, and also inhaler technique, teaching and assessing inhaler technique is of prime. If somebody isn't controlling their eczema well, we need to look at their drug therapy and look at what treatment they're on, what treatment they need to do. There's a lot of assessment that goes around what they're on, inhaler techniques, and stuff like that. And it's often very classic that people may have been taught that their inhaler technique isn't very good, which means they're not getting the dose in, which means this is why they're in trouble and they could be at risk of deteriorating forward. Again, exercise, dietary, again, obese and all that kind of thing, asthma control, if allergies related to food, etc. So there's quite a health promotional role within this. Patients should have an action plan, and also patients should be taught how to manage their asthma. Very much put patient focus, putting the patient in control, because that works and that helps people get the best out of it. Recognising early symptoms, thinking about what to do to avoid allergens. The other thing I talked about, the changes in weather temperature in spring and autumn, is another thing to recognise that, you know, if things are warm 1 minute and then going cold quite quickly, these things can trigger, and it's about avoiding that and being able to manage those kind of things. What all asthmatics and majorities and all COPD patients should have is a plan. It's a plan that they manage themselves, recognising that something might, you know, that they're becoming affected, their breathing's becoming difficult, taking early treatments called step treatment. Do have a look on Asthma UK. It's all about step treatment self-management. The web links are at the end. What are the differences? COPD is irreversible. It's caused by smoking, occurs in later life. Lots of things happen, long deterioration, limited benefit from bronchodilators. There is some research into drugs that may actually quite help. One of the classic ones they talk about is that patients were reporting to their GP, gentlemen who were taking Viagra reporting to their GPs that their breathing problems had also gone, and wasn't that wonderful when they looked at the way in which the chemical formulary of Viagra is made up. So the company that makes Viagra is now doing quite well because they are reformulating it to look at treatment for COPD. And there's a thing for you. Yeah, high mortality. Asthma, reversible, pollutants, younger people and old people, breathless wheezing. They do well if managed well. And here's some clinical features of the difference. Again, just to sort of give you that overlying things and just reiterate some of the things that I've been talking about. Diurnal daily symptoms here, this means, well, day-to-day various symptoms. Quite often with people with asthma, they'll get their attacks in the early hours of the morning or their worst first thing in the morning. Part of that's laying down, and part of it is this sort of allergy thing start to trigger in as well. Again, nighttime waking, breathlessness, persistent deterioration. So we see some of the fors and against there. Here's some further reading. Please look at NICE guidelines, but please also, you know, have a look at some of these bits and pieces when it comes relevant to you. Some of you may be looking at thinking about doing case studies with people like this, and that there's an opportunity then to return. British Thoracic Society are also really key in developing guidelines, and you'll see that with NICE. Someone said, what was that about COPD? It was actually Viagra. The new drug they're making, I can't remember off the top of my head, and it's just one of those kind of things I found at a conference recently. They were talking about how people that were taking Viagra were reporting that their COPD was actually pretty impressive too. There's a lot of stuff out there if you're looking at COPD and asthma for you to look at. And as you might have gathered, the big thing is, as well, when you're going out in the community and then community practice with the district nurses, such like that, GPs get extra money for regularly checking people with COPD and asthma. So if you're going out into GP practice, you'll see clinics especially for COPD and asthma patients. You'll see that. The other thing that you will see is people like community matrons who will be regularly visiting people with COPD to help them with their therapy. And you will see specialist nurses for asthma, specialist respiratory nurses. So where relevant, get the opportunity to spend some time with them, because they're all about helping people live life well with a long-term condition. I mean, that's the same with any long-term condition you choose to explore. You'll always find that. But you know, for respiratory, there's a lot of interesting things to find out about how rehab classes for people to go to learn how to adapt their life and their homes to improve their quality of life. So there's a whole range of opportunities that you can pathway into. So without further ado, I am going to stop this, and thank you very much for your feedback and your discussion points. I'm only 6 minutes overrun, which isn't bad, and enjoy the rest of your day. I'm going to stop the recording.